Hello, everyone. I am just going to give it a couple more seconds to allow people to trickle in. Okay. Looks like the attendee numbers are still moving up a little bit. Um, Okay. Well, hello, everyone. Good morning, good afternoon, good evening, wherever you are located. I know it is good evening where our presenters are at. So I am Casey Coletti. I am the Community Engagement Manager with Mission MSA. We are very excited for this webinar today, Pain in Multiple System Atrophy. I am going to go ahead and pass it off to Professor Fanchuli and Dr. Campese. And if you have any questions throughout the webinar, please feel free to use the Q&A function. They will be answering live Q&A after their presentation. But guys can go ahead and get started and yeah.
Thank you for the introduction, and thank you for the opportunity to have this webinar tonight with Mission MSA and the Mission MSA community. For us, it is a very important moment today, and it is very important for us to talk to you about these results. And it is also the way we would like to express our gratitude to Mission MSA, which eventually supported this research financially, and also to all the people with MSA worldwide and the MSA caregivers, which took part in this web-based survey, which you might have seen in the media, and helped us gain mindful insights in pain in multiple system atrophy. My name is Alessandra Fanciulli. I'm the director of the Innsbruck Dysautonomia Center, and my research focus is multiple system atrophy and other neurodegenerative disorders. Specifically, I focus on autonomic failure and other non-motor symptoms, including pain. And it is my pleasure tonight to share this webinar and this minutes with Dr. Campese, Nicole Campese, who, like me, is from Italy and is doing a marvelous PhD in our group. So good evening, Nicole.
Good evening, and thank you for the invitation.
So we will now just start straight ahead talking about our topic tonight, so pain in multiple system atrophy. As we know, and the name of multiple system atrophy tells, the disease is much more beyond the motor issues. So multiple system atrophy is traditionally known as a movement disorder, but we know that beyond Parkinsonism, so the slowness of movement and rigidity, and beyond cerebellar ataxia, which is this difficulty in coordinating, there are many other symptoms because the autonomic nervous system is also severely impaired in the disease, and so problems with your circulation may occur, with your blood pressure, with your bladder empty, and with your belly empty as well. There are also other symptoms which must not but may occur during the course of the disease, affecting sleep and mood. But we have understood in recent years that there is a big elephant in the room, which has been a bit neglected, I would say, in MSA research and clinical practice until recently, which is pain. This is a post which we took from Facebook of a person living with MSA, and you can already tell from the number of emoticons in the text that this is highly emotional. And she tells that thanks to a better pain control, she was able to cook a good dinner. And to me, so I was really struck by a sentence I read in this post, and it says, maybe to someone who does not have MSA and whose life is not ruled by pain, this whole post sounds kind of ridiculous and silly. So for me, this was really the sign that a lot needs to be done to better treat MSA and pain in multiple system atrophy. Ultimately, we do take this symptom very seriously in our clinical practice. But this post was also the beginning and also conversation we had with previous board members of Mission MSA. Back then, it was still the MSA coalition, made us understand that pain is really a, a troublesome issue in daily life of people with MSA. And so the first thing also that we doctor did was to go on Facebook and have a look at the post which people living with MSA and their caregivers wrote about pain. And this is just an excerpt, another one, which was very, very impressive. But what you see on the right is a word cloud, so that Nicole generated with all these posts and gives us the impression how important and impactful pain can be in the life of people living with MSA. It is indeed frequently reported, but as it seems, poorly recognized and managed. Now, which is the medical definition of pain? You can read it here: an unpleasant sensory but also emotional experience associated with an actual or potential tissue damage or described in terms of such damage. But this is a bit a complicated definition. Let's go step by step and let's understand together what does this mean in the context of MSA. When we started this project, and this is how researchers do in every field, before you start setting up your project, you have a very, very close look at the literature to understand what is already known in the setting of MSA and pain. And this is what we did, again, together with Nicole Campese. We performed a so-called systematic review and meta-analysis of the literature. Again, a very difficult word to say, that we went very carefully and with a specific method through all the literature available in pain with MSA. And the first question, of course, was how frequent is pain in multiple system atrophy? And the literature says that every second person with MSA reports pain. And then we asked, so who is most frequently affected by pain? It seemed from the literature that this is more common in the so-called Parkinson variant of MSA. That means the variant of MSA where slowness of movement, rigidity, and postural instability are the major motor symptoms. And it also looked like in the literature, we saw a trend towards higher prevalence, so that pain was more frequent in female individuals. However, this was not really clear. And then after going through the literature, we had more open questions than the ones we had and than those we had at the beginning, because we asked ourselves, what kind of pain do people with MSA have? There are many different, and this is important to understand because the time of pain, whether, for example, is a problem of the joints or of the nerves, will guide your therapeutic approach. But this was not clear in the setting of MSA. Then we asked ourselves, where is pain most frequently localized? Because it could be all over the body. And the literature was not clear to this end. And eventually we asked, so how often do people with MSA have pain? So is it a pain which is continuously present, or you have pain bouts, or a combination of both? The literature provided no answers. And the same applied to treatment. So we saw from the literature that every second person with MSA might receive any kind of pain treatment, but we had no idea what kind of medication and with which efficacy and safety profile. So we as a doctor, if we would like to ask the literature, what should I recommend the person with MSA I'm treating who has pain, the literature provided no answer, and this was not good. And there was another important aspect. As we know by clinical experience, unfortunately, that as MSA progresses, or when we are reach the advanced stages of the disease, it gets very difficult for people living with MSA to come to the reference center like ours and a few others around the world for controls. So what happens from the physician's perspective is that these people at some point are unfortunately lost to follow up. And we don't know what happens in these advanced stages of the disease where many symptoms often comes together. And in all this context, at some point, the pandemic arrived, and with all this lockdown and social isolation and all what we have all gone through, this isolation and this difficulty of people living with MSA to reach the center only increased. And we went through quite some dramatic years. But as always in life, also bad things have some silver linings, so some positive aspects. And this we have learned to appreciate and make use of in research. So which was the silver lining of the terrible pandemic cloud? The silver lining was that both the general population and clinical practice, so healthcare provision, got significantly digitalized. So we are now perfectly comfortable with sharing also very private things online, but we are savvy, everybody's savvy in using, for example, WhatsApp or the social media, Facebook, Instagram, and so on and so forth. And we have also learned to exploit this to get better in contact with the people we under our care, for example, with telemedicine. And this was the idea we basically used or exploited, if you want to use this word, to build up our study. So we thought, okay, we are in the pandemic, people living with MSA might have difficulties to come to our center. In some countries, there are no MSA centers, or people may eventually not be able or interested in joining us in Innsbruck. No problem. We reach them in another way, or that we reach people with MSA and their caregivers through a web-based approach. So this was the survey. You see it here in German, but there was an English version as well. And this we promoted thanks to the support of Mission MSA, which sent this through the newsletters, a few other also Germany, so advocacies, and also social media. So you see, maybe you saw that this was the post we had on Instagram, and this was the one we had of Facebook. And here I would like to pay a tribute to really a MSA giant, a research giant, which we have unfortunately lost earlier this year. This was Professor Wenning, which you see here in the picture. He was the lead of our group. And when we launched this survey, so he was very supportive of our project, of our initiative, and he also posted this on Facebook, on his personal Facebook account, which many people with MSA were reading regularly. And as you see here, within 3 days, this survey was spread all over the place, reaching eventually, we hope, as many people as possible. And now it is a honor for us today, and again, a tribute which we pay to Professor Wenning, to Mission MSA, which give us trust in doing this research, and the people with MSA and their caregivers who took the time to answer our questions, telling you about the results. I will now take over, so give the word to Dr. Campese, who will lead you through the main results of this paper, which was published last month in Movement Disorders. And if you're interested, you can also download it. It is in open access, so you don't need to pay any fee to read this research. So please, Nicole.
Thank you, Alessandra, and thank you all for the attention and the invitation. So what did we learn about pain in people with multiple system atrophy thanks to this community-based survey you kindly contributed to? First, it could sound quite trivial, but I would like to stress it once again. This is a concept that we already came across at the beginning of the presentation. Pain is a very relevant topic for the MSA community. And this is attested by the very large participation in our survey we had. We received a lot of questionnaires completed by persons living with MSA and their caregivers. We had, of course, to exclude a couple of questionnaires because they provided the information they provided were incomplete, but at the end of the day we were able to analyze questionnaires completed by 190 persons living with MSA and 114 informal caregivers, which is a very high number of questionnaires. And I would like to take the opportunity to thank you once again for taking the time to complete the questionnaires. But coming to the core results of our study. What did we learn? First, pain is highly frequent in MSA, and about 87% of persons living with MSA who completed the survey reported that they had experienced any kind of pain in the 30 days before survey completion. And most vulnerable were female individuals and individuals coming from low-income groups. But what features has pain in MSA? The most common locations of pain in MSA are the neck and shoulders, followed by the back and the legs. And I think this is even more important. About 70% of persons living with MSA reported that they had experienced pain in more body regions at the same time. But also, pain intensity was quite heterogeneous across different body regions, and we observed that the most intense pain was experienced in the back, in the head, and in the feet. But what about pain frequency? We asked about pain frequency, and most of the participants reporting pain reported that they experienced pain almost daily or several times per week. And this is, I think, a very important take-home message, because this means that persons living with MSA, for persons living with MSA, pain is mostly a daily issue to deal with. And most of the persons participating in the survey and reporting pain reported that pain was experienced as an episodic recurrent pain. That means that persons experience pain exacerbations followed by pain-free intervals. But we observed that pain tends to be more continuous and more intense in the more advanced disease stages. And this is a very important message, in particular for the caregivers and for us as doctors, to pay attention to this overlooked feature, in particular in the advanced disease stages. But first take-home message, pain is highly frequent in MSA. Then we came to the question and asked ourselves, asked you in the survey, how does pain impact on daily life? And we learned that pain impacts on work, household activities, and hobbies of people living with MSA. But on the other hand, the other side of the coin is that pain of people living with MSA also impact on core activities of daily living of their caregivers, and in particular on social activities. So we have two key concepts. Pain is frequent, and pain is a very distressful feature impacting on core activities of daily living. So we asked ourselves, and we asked you, how pain is currently managed in MSA. And we learned that most of the patients experiencing pain manage their pain alone. And when a healthcare provider is involved in pain management, this is typically a doctor. And among doctors, the most frequently involved are neurologists and general practitioners. But what kind of medication do persons with MSA experiencing pain use? Mostly non-steroidal anti-inflammatory drugs and acetaminophen that we know represent the lowest level and therefore the less specific and also the less effective level of the so-called WHO pain medication ladder, which is a kind of guidance that doctors use to tailor pain management in persons experiencing pain. But of course, we don't have only pharmacological treatment strategies. We have also non-pharmacological treatment strategies, and we explored also which non-pharmacological treatments are used by persons with MSA experiencing pain. And we observed that physiotherapy and massages were the most commonly used non-pharmacological approaches to treat pain. So we have a very common, very distressful feature, but we come now to what I think is the most important question today. So are these management strategies that we briefly overviewed satisfactory? We asked you in the survey if you are satisfied with your current pain management, and what we found is that only about every second person with MSA experiencing pain reports to be at least partially satisfied with current pain management. But we know that according to the Declaration of Montreal, access to pain management is a fundamental human right. And we will discuss now which kind of strategies we can have to ameliorate or relieve your pain.
Right. So the real world experience which we gained with this survey told us a slightly different story than what we have learned from the literature, from the previous literature, and tells us also that center-based approaches, so research done in referral centers, is highly important, of course, to understand and the mechanism of disease and develop new treatments. However, it is very important to listen to the MSA community, because the real world experience, especially if you do not have access to a referral centers, might be slightly, and this is euphemistic, different. But then, and here starts again a bit the medical work behind. So why do people with MSA develop pain? Ultimately, and this is a hypothesis which we have ourselves formulated by studying all the literature and the evidence, different mechanisms may contribute to pain development. Which are these mechanisms? There are likely psychosocial factors. There might be financial issues which preclude you to access the health care you would necessitate of, and this is this association we have found with a lower income. But there may be also gender issues. So female gender has been shown to be associated with pain, and this might be due to some hormonal aspects, but also to some behavioral aspects. Not last but not least, maybe we hypothesize also in the relationship between the person living with MSA and the physician or the caregiving context. Then there are biological factors, so possible contributors to what we would define neuropathic pain. What does neuropathic pain mean? This is pain which derives from a lesion of the autonomic nervous system. It has indeed been shown in MSA that there might be problems with the cortical pain processing, so in the higher structure of your brain, in the processing which occurs in the basal ganglia, which we know are affected in MSA. The degeneration of some brainstem serotoninergic and noradrenergic nuclei might play a role. The spinal cord affection with all the ascending fibers and also loop controls, and eventually the nerves, the peripheral nerves, which have been shown in MSA also to be affected by the so-called synuclein pathology. But on top of this, and this is what we have observed in our survey, is that there might be some MSA-specific sources of nociceptive pain, so some causes of pain. Which could be this? For example, fall-related injuries. or abnormal posture and cramps, or the so-called Kodanger pain, or a pain due to bloating, constipation, or incomplete bladder emptying, or the so-called cold hands and feet, which are very frequent with people with MSA or pressure sores. But this was an hypothesis, and what we saw in this study, and we were really this was a very mindful insight. So we had a look, depending on the body region which people were reporting to be painful, we looked into association with our other clinical features. And as you see here, we found many, but I would like to draw your attention to just to a couple of these. First, pain in the neck, legs, and hands was associated with dystonia. Dystonia, per definition, is an involuntary muscle contraction which produces an abnormal posture. As a frequent one is the so-called head drop, antegolis, or sometimes this dystonic posturing of the legs, so when your foot goes to the inward, or of the hands. And this is important to know because dystonia requires a slightly different treatment that, let's say, other types of pain, like if you have a joint pain, for example. Physiotherapy and physical activity are very, very important in people with dystonic features. And so you might, for example, refer to this is one of the first physiotherapy study in people with MSA, and there are some exercises which you can find online, and there are more studies ongoing by the colleagues that will be published any soon. But then there is another aspect, which is treatment with levodopa. In people with MSA and dystonic features, levodopa can have a dual effect, because sometimes when people with MSA take levodopa, they might have an exacerbation of the so-called dystonic posturing, especially in the face and in the neck. So they have this painful contraction, and sometimes in the hands and feet. On the other hand, especially in the first years of the disease, levodopa might help improve rigidity and slowness of movement and dystonic posturing. So it is very important that the neurology is made aware there's pain, and then the neurologist assess which is the relationship to levodopa, if more or levodopa might be better for you. And then there are also specific interventions which you might discuss with your physiotherapist. For example, in case you have antegolis, this so-called dropped head, this turns to be very painful and could have consequences also on your on your bones, on your neck. And so, for example, there is this orthosis which is devised to enlighten the pressure in this area. This is something which your physiotherapist or your rehabilitation doctor might advise you whether it is good for you. And another thing which we looked at, this is another factor associated with pain, which I would like to draw your attention to, is that in the chest, in the head, and especially in the neck and shoulders, pain was associated with orthostatic intolerance. And this we knew when we saw this association, we thought, well, that makes perfectly sense, because indeed we know that this coat hanger pain, which is pain in the neck and shoulder region, just like a coat hanger, is due to hypotension-induced muscle ischemia. So your neck muscle, due to orthostatic hypotension, so this low blood pressure when you're standing, are getting pain because they do not have enough blood, not there enough oxygenation. And so it is very important that that the attention of your treating physician is drawn to the different forms of orthostatic hypotension that people with MSA might develop. The most frequent one is the so-called classic orthostatic hypotension, so this which develops within 3 minutes, but sometimes, especially at the disease beginning, this is only present briefly when you stand up, and then you kind of compensate, but might come again if you stand up for longer time, this is so-called delayed orthostatic hypotension, or for example, get worse after the meals because all your blood goes in the belly for you to digest. Or if you perform some physical exercise, then your blood will go to the muscles and then orthostatic hypotension might exacerbate. What can be of help? There are some, so the first thing to treat orthostatic hypertension is to treat exacerbating factors. So is there an intercurrent infection? Is there anemia? Is there a problem with fluids which need to be reintegrated? Are there maybe drugs with blood pressure lowering drug in the schedule? So the GP might have a look at that. And then there are behavioral measures which you yourself could implement in your daily life to feel a bit better. For example, things which people with orthostatic hypotension should avoid: heat exposure, large meals for this so-called postprandial hypotension, which I mentioned, or alcohol consumption, because alcohol has a vasodilatory effect, so your blood vessel become broader, and also has a diuretic effect, so you lose water from your kidney. And things you might do to improve your orthostatic hypertension. So when you're standing, clenching your fist or your buttocks or crossing your legs, this might be a bit tricky for the balance, but contracting muscles can raise the blood pressure, and also increasing your fluid intake, your salt intake, or raising the head of your bed while sleeping. This has an effect on the baroreflex, or wearing compression garments like an abdominal binder. Eventually, there are pharmacological options that can be considered and should be considered in case of severe orthostatic hypotension, sometimes in combination. So which are these options? Some studies work with pyridostigmine, which enhances the ganglionic transmission. Other studies, and if you live in the US, you have access to this drug, which is droxidopa. It is a noradrenaline precursor. Sorry, the slides are running by themselves. There is a study ongoing with ampreloxetine, which should increase the noradrenaline transmission. And there are eventually also drugs to stimulate the noradrenaline receptors in the blood vessels so that they get constricted. Unfortunately, currently in Europe, we have some delivery problems for these drugs, which make quite some troubles in daily life of people with MSA. Another approach which could be considered is fludrocortisone. This is a synthetic hormone which makes you retain more fluid and salt from the kidney, and so expand your blood volume and raises your blood pressure. What we combine mostly is that a combination of midodrine and fludrocortisone. And in case of postprandial hypotension, there are also some non-pharmacological measures. One important thing, for example, is to fractionate the daily caloric intake in smaller meals. And so the bigger meal shouldn't be lunch, but dinner. Also avoid alcohol intake at mealtime. And there are some pharmacological options like low-dose caffeine before the meals. This also helps raise the blood pressure, and some others which are borrowed from the diabetes therapy like acarbose or subcutaneous. This is really, but this is in individual cases, the octreotide option. So basically the take-home message is, if you have muscle cramps, or if you have problems with low blood pressure, if you have any kind of pain, it is very, very important to talk to your doctor, ask the doctor to take 5 minutes more and look for this relationship. Why? Because these are specific causes of pain in MSA, which are not to be treated with opiates or with NSAIDs, but require a specific treatment which your savvy neurologist will be able to offer. So this was basically what we wanted to share with you tonight or today, because I appreciate in the US it's still midday, and we are here and happy to take questions. I would like to thank once again Mission MSA, and particularly I would like to mention namely two people who were very important in the setup of this project, who are Larry Kellerman and Pam Bauer, who were really supportive of us initiating this study, and all the people with MSA and their caregivers who took the survey and made this study possible. Thank you once again by heart. So I stopped sharing now, and there are some Q questions. Sorry, I just need to just like to clean my nose, please.
I can read it as well.
Yes, please.
So we have a question here. My wife and I noticed that when low pressure weather systems were in the area, her pain was worse. When there was a high pressure system, her pain was less. A member of a support group made a similar observation in a recent meeting. Did you find any evidence or has any question been raised regarding this phenomenon?
This is a very interesting observation. Actually, no, I'm sorry, this we did not ask. And we are not aware of this kind of data in the literature. But what could be is that when the weather is hot, for example, orthostatic hypotension may get worse. Your blood pressure might be lower, and this worsen eventually this kind of pain related to orthostatic hypotension in the head, neck, and shoulders. I'm not sure about pressure of the weather. Then I see another question. So jaw pain radiating into head. This is very interesting. For example, so jaw pain, I don't know whether you have any problems with your feet or with your temporomandibular articulation, which would be, let's say, unrelated to MSA, but sometimes this dystonia, which I mentioned, specifically affects this region of the face and of the neck in people with MSA. So if you're taking levodopa, any dopaminergic medication, you might talk to your doctor if there is a relationship between this pain exacerbation and dopaminergic intake. So is gabapentin effective for pain? This is a very wise question. Eventually, we believe that gabapentin can be a helpful approach in case of the so-called neuropathic pain. So it is this burning pain which feels like needles in the legs, for example, or in the feet or in the hand, could be an option. An important thing is to pay attention to is that gabapentin may at the beginning, when titrating the medication, so increasing the dose of the medication, could cause some dizziness or balance problem, and so it should watch out for the risk of falls. So what is the most effective approach to treat muscular pain? From the atrophy weakness that muscle loss generates as the muscles diminish in strength, the pain increases tremendously. Right, yes. Maybe physiotherapy, I think. Would you like to take this question?
Yes, you should discuss with the treating physician the details of the weakness you experience and the exacerbation of your pain, because in this case, physiotherapy or massages or physical maneuvers can maybe help. but it's very important to properly identify the type of pain you are experiencing in your muscles. Do you agree, Alessandra?
Yes. So a very important thing that physiotherapists also can help is prevent contractions. So this stretching exercise is what people might describe as massage could be uh, a helpful thing. And strengthening exercises tailored to the capacity, so to the limits of the person, can be also very, very helpful. Also because through movement you improve the muscular perfusion, and this might reduce the pain. Yes, so a bit of active exercise as much as possible, and a bit of passive mobilization if you have really painful heart contractions which you cannot control anymore yourself. So this is a research question. How might a research project be set up to study specific aspects of the results you found? Might a center of excellence or a group of centers set up a research opportunity regarding one or more aspects you have found? Yes, actually, yes. And we had some discussions also with Mission MSA last year regarding this, but we were in early phases of the data analysis, which we completed. So we were able to publish a few months ago. I think we can disclose this. We are setting up an additional cooperation with the colleagues from London at first to start working on a diagnostic tool for pain in MSA to understand all the different pain types. So we cannot take for granted what applies to Parkinson's disease and using in MSA. We need to work on that. So tools to measure and screen for pain. And of course, then we will need at some point when we have better understood the mechanism, underlying painful sensation, and start trials. And for trials, it's always good to work in a network. Of course, there is a bit of a difficulty there because there are many regulatory aspects to take care of, and there are some costs which are a bit difficult to cover in the field of MSA with limited industry support. But we are working on this step by step, and we think that as the first very important step is to raise the awareness for what we have found, to share this information also for the people with MSA, so that everybody is empowered also to speak out and ask the doctor, hey, does this condition apply to me? Could it be that I need a better control of my orthostatic hypotension, or can we do something if I have dystonia? And so have a immediate impact on daily life and on clinical practice. So that means that there's a long way ahead, but we are proceeding step by step and going on. Do you think, so is it typical for blood pressure to be high in the AM and 3 hours later be dangerously low? Nicole, please take this question.
Yes, it's quite typical because um, the counterpart of orthostatic hypotension, which is this blood pressure drop you experience when standing up or while standing for a longer time, is the so-called supine hypertension. So the problem here is not only that the blood pressure goes low, but also that the blood pressure goes high while you are lying in the supine position. And of course, in the morning, you just wake up and you have been laying down for the whole night. And that's the reason why the blood pressure values are increased in the early morning and then drop down. There are some measures, non-pharmacological measures, that can be used to prevent supine hypertension. For example, sleeping with the head tilted up 20-30 degrees. For example, you can use you can just raise your head and trunk. You should, if possible, try to reduce the fluid intake in the late afternoon and in the evening, and try to increase the fluid intake in the early morning, just to compensate this blood pressure drop. You can also take a snack before you go to bed, because we saw in the picture that Professor Fanciulli already showed you, that the blood pressure tends to drop down when you eat something. So we are using this kind of adverse effect that is produced by the meal intake to prevent the blood pressure rise during the night time. And then, of course, if the blood pressure is too high, you need to discuss it with the doctor. You can take some notes of your blood pressure values in the morning, because sometimes a pharmacological treatment could be needed, but this is something that you need to discuss with the doctor.
So we have many other questions. We'll take them one after the other. Do you think there's a correlation between a spinal cord injury in an MSA? If so, how? I'm not sure I understand this correctly. So a person who had a past spinal cord injury and then developed MSA, this is a seldom combination. However, spinal cord injury might exactly also produce problems with blood pressure regulation, problem with bladder emptying, with bowel emptying, and cramps, depending on where the spinal cord injury is, in the legs or also in the arms. So this is difficult to tell here in general methods. Otherwise, if I did not understood it correctly, so whether there's an involvement of the spinal cord in multiple system atrophy, yes, this is the case. So the intermediate lateral column are specifically involved in people with MSA, and this is the base for orthostatic hypotension. And also the sacral spinal cord can be involved and causes this bladder and bowel problems in people with MSA. The degree of impairment of the sensory fibers, ascending sensory fibers, and loop control system is not well studied, however. How can MSA patient distinguish between pain directly associated with MSA and something else? How long is carbidopa effective? Oh, you shouldn't be left alone to make this distinction. This is very difficult also for ultra specialized doctors. So try to sort out what is what. You should definitely ask your doctor for help, your treating neurologist, who to help sort out things, because there are indeed some specific questionnaires and also tests which can be done to understand, to better understand which is the underlying cause. How long is carbidopa effective? So I guess levodopa, carbidopa, so the combination of the two. Studies says, or natural history study say that in the first 3 years of the disease, there might be an even good effect of levodopa. And that's why if Parkinsonism is present, levodopa should be tried. What can happen when the disease progresses, and this is usually the case in MSA because the putamen degenerates, that this response to levodopa fades away, or that side effects to the levodopa arrive. Example, this dystonia exacerbation, or sometimes also the exacerbation of orthostatic hypotension. So if you start noticing that levodopa does not work good for you, or you experience the side effects, this is very important moment to talk to your doctor again and reconsider if the medication schedule is the appropriate one. I have sharp pinprick pain in random areas, goes away very quickly, but increasing in frequency. Have you seen others experiencing? Well, I guess this is what other people might describe as diffuse pain, and indeed it might occur. It is not very frequent, but could happen, has been described. Can you in future please cover MSAC? So you mean in the talks? I'm not sure whether I understand, or in our research. So when we do our research, we have some protocols and which are from PNC. In this case, we were talking a lot about dystonia, and maybe it is true this occurs more frequently in the P variant of MSA. In the MSAC, we saw that pain might be a bit less frequent. And it is true for MSAC, for cerebellar ataxia, we have less options available to improve the motor part. So physiotherapy is actually the most important weapon we have in our hand for MSAC. Does localized heat help with muscular pain? I guess so. At least I guess it would be good to give a try. So this is my empirical experience. Just pay attention, because if the area you're exposing to pain is wide, for example, the back, the belly, so a wide area, this might lower the blood pressure. So it's perfectly fine if you apply some heat therapy, but then pay attention when you stand up, not that your blood pressure gets too low because of the vasodilation. So please, Nicole, please take a couple.
My pain also comes and is stronger when my body gets very hot, where so it comes down in air conditioning. I guess this is not so well documented, at least in the literature.
Well, it could be that, so sometimes people with MSA, it is difficult to tell if we don't see each other live, but sometimes people with MSA have difficulties in disperse. Heat, because sweating is impaired. And when the body gets overheated, this might be a source of pain. In this case, and I don't know if in your specific case this has been tested, that your sweat production, your doctors say pseudomotor function is impaired, but might be of help to use some cooling garments. So to try to cool down your body with some. So there are some which are like a jacket, some like a hat, or simply some wet pads applied to your body. This might be helpful in summer, for example, when overheat can be an issue. Not pain, query associated with pain, though. Upper body functions, flatulence, bowel movements, I guess, and urination. I get excessive entire body sweats, very warm at the time. Goes quickly afterwards, usually. Have you heard of this? Sounds like autonomic dysreflexia. This is a problem with people with spinal cord problems have. Not really, not really. I'm sorry. This I did not hear, but I guess it is so. Constipation is an important issue that needs to be treated, and also complete bladder emptying is important. So there are measures for constipation which can help. Some are non-pharmacological, for example, including the amount of fibers in your diet and also fluid intakes. And we know that this is sometimes difficult. Uh, a belly massage clockwise. This has been also shown to help emptying better the bowel. Uh, Movement eventually, so immobility is a risk factor for having worse constipation. And then there are some drugs, like for example, macrogol or natrium picosulfate, which can help soften the stools so that you do not get into these big troubles with bowel emptying. Regarding bladder emptying, this is also, sorry, I have a bit of a cold today. For bladder emptying, if you're not able to fully empty your bladder, this is also very frequent in people with MSA. There might be the need for catheterization. So this is something you might talk to your urologist whether it is needed in your case because the bladder is overfull.
So there is the last
Yes,
one.
please.
How do you best treat pain due to cold hands, feet, apart from trying to keep them warm? So unfortunately, there's no large evidence regarding these painful sensations related to cold hands, cold feet. It is reported, but it's some of the, so to say, new findings of our study. Um, the cold hands and cold feet are related to problems with circulation within your extremities. So the strategies are to try to keep them warm, also with local heating, but also you can try to activate your muscles because this increases the blood flow in the region and can ameliorate this painful sensation related to cold hands and cold feet.
True. So,
Okay, it looks like you guys answered all of the questions. Are there any last minute questions or we are gonna end right on the dot? Um, oh, it looks like we got one more. Is it okay if you answer it?
let's give it a go. Okay, so pain in legs constantly, but gets severe early evening, never while sleeping. Doctors say RLS. Currently taking Horizont and Carbidopa. Anything else? I'm sorry, I need to counter check what Horizont is because maybe its name is gabapentin. Is this gabapentin? It looks like it.
Yes.
Is this gabapentin? It's horizontal, I think gabapentin medicament. Okay, so sorry, I had to look it up because it has another commercial name in Austria. Uh, there's an important thing for restless leg syndrome, which might be the case if your doctor made this diagnosis, to have a look at the iron levels in your blood. So if you have an iron deficiency, this could worsen your restless leg syndrome symptoms, and specifically the ferritin level should be above 75 milligram per deciliter. So should be more than enough. You should have more than enough iron in your blood to treat RLS. And actually, gabapentin is a good option. I don't know about the dosages. Other options which can be tried are also for similar classes like pregabalin.
Awesome. Well, I think we will wrap up now. And looks like we had a good amount of attendees, so thank you all for joining. This is being recorded and we will post it within the next week. It looks like we're getting a lot of thank yous in, so I am so glad you all enjoyed this. And thank you to you, Professor Fanchuli and Dr. Campese. I think this was very well received, and I'm so appreciative of your guys's. I know it's nighttime, so I hope you
It's
guys
okay.
have a wonderful rest of
We
your
are
evening.
again very grateful for first supporting our research. We're grateful again to the people who shared their experience and made us understand a bit better where to start working in the next years. And of course, also for the opportunity to uh, talk about the results of this research. Thank you.
Awesome. Okay. Thank you, everyone. Bye.
Ciao. Have a nice
Bye.
evening or have day.